and sexual dysfunctions. The sacrum, we have to know some anatomy about the sacrum. The sacrum, it is upside down. The base of the sacrum, it is the base, the apex, and the fourth surface, which is the pelvic dorsal and right and the left edges with the sacral canal. The base is a concave surface facing forward and downward and forward. And the feature is there is a transverse ridges, which representing the fusion of the vertebra, anterior sacral foramen, the ventral lemma of the upper four nerve root coming from it, and the lateral mass, the lateral to the foramen. The muscle attached is the piriformis coccygeal and the sacrospinous ligament. There is a five vertical crests, the median crest, which is prominent, and the two intermediate sacral crest and the two lateral sacral crest. The sacral hiatus, which is it is inverted V-shaped structure in the dorsal surface and formed on each side by the sacral conio. The muscle attached to this surface is the rectospinalis multifidus and the gluteus maximus and sacrotibius ligament. This is the lateral surface of the sacrum, which articulated with the ilium, makes the sacroiliac joint. The sacral canal, which is contains the lower part of the coda equina, pallium terminalis, the spinal meninges, lateral sacral vessels, and the dura and arachnoid extended up to S2. What about the nerve? The nerve, the L5 nerve root running on the top of the sacral ala, and L5 and L5 to S5 to S4 nerve root are transmitting through the sacral foramen. The S1 and the S2 nerve root carries a high rate of injury. The lower sacral nerve root, S1 from S2 to S5, the function is anal sphincter, bulbocavernous reflex, and free anal sensation. Unilateral preservation of the nerve is adequate for bowel and bladder control. The biomechanic, it is supports the vertebral column, forming the posterior part of the pelvic, and transmission of the load distributed by the first sacral segment through the iliac wing to the acetabulum. This is the main arc, and subsidiary arc is the main arc, which is coming from the vertebral body to the sacroiliac joint to the upper end of the femur in both sides. The subsidiary arc, which go to the anterior superior spine, to the pubic rami. What about the foramen? It is very important to know there is a four pairs on both ventral and the dorsal surface of the sacrum for existence of the anterior and posterior primary division of the sacral nerve. Notice that the ventral foramen are larger than the dorsal sacral foramen. The four transverse line on the pelvic ventral surface that indicated where the fusion of the vertebra occurred after the 20 years. The base of the sacrum is the superior surface of the articulated with the superior surface with the first sacral vertebra. The superior articulation process of the sacrum articulated with the inferior articular facet of the L5. The sacral promontory, the projecting anterior edge of the body of the first sacral vertebra. This is the content and the nerve and the relation to the ventral aspect of the sacrum. And this is the lateral view, the relation between the vessels and the sacrum. So it is very important to exclude the internal hemorrhage when you have an injury to the sacrum. This is the views of sacral plexus and how it is crowded, and any injury can be leading to a neurological deficit. This is the sacral plexus, and all we know about is the importance of this for the lower limb. And this is the sacral plexus also from anterior and lateral. And we have to know the dermatome for examination. S1 around the anus, S3 around the gluteal fold, S2 around the posterior aspect of the side and the leg, and S1 is the heel. What about the classification for this fracture? Dennis and Davis have making a sacral fracture an important problem retrospective analysis of 236 cases in 1988. And he classified this bone into 3 parts. Dennis' 3-zone classification system in 1988 based on the fracture anatomy. The zone 1, which is the fracture lateral to the foramen, most common, 50%, and there is a nerve injury rare, it is accounting by 5%. Zone 2, which is including the foramen, fracture through the foramen, and may stable or unstable. The zone 2 fracture with sharing component, high unstable. Unstable fracture have increased the risk of non-union and poor function outcome. Zone 3, which is a fracture medial to the foramen into the spinal canal and high rate of neurological deficit, about 60%. So this is, we will go through this is the zone 1 across the sacrum and with the neurological deficit. Like subdivided into stable and unstable injury according to the 3-stage severity system. Neurological injury occur in approximately 6%, as we mentioned before, of the patient and typically involving L4 and L5 nerve root. About zone 2, which is through the neural foramen and the neurological deficit, always affecting the L5 to S1 about 50%. Always the unilateral sacral anesthesia can be presenting as a clinical pictures. Incontinence can be occur, flaccid bowel and the bladder can be occur, and at the end impotence. You have, when you examine this patient, you have to examine for the Achilles tendon because it's S1, pulpocavernous reflex, and the rectal tone is very important. Zone 3, which is a fracture in the middle of the neural foramen and involves the spinal canal, and always there is a neurological injuries. About 56% of the whole with the coda equina with neurological bladder, saddle anesthesia can be occur, and the loss of the sphincter when you examine this patient, and the bowel and the bladder function about nearly 70%. This zone can be sub-classified into 4 types. Type 1, only kyphotic angulation as a fracture side, not translation. Type 2 is a kyphotic angulation with anterior translation of the distal sacrum. Type 3, which is a kyphotic angulation with complete offset of the fracture fragment. And type 4 with a comminuted S1 segment, usually due to the axial compression. This is another classification, go for morphological injury. The other one is anatomical, and this is morphological of the zone 3 into H-shaped, U-shaped fracture, inverted Y and T-shaped fractures. This is the morphological injury pattern in zone 3. Isler classification in 1990 uses the fracture for the sacroiliac joint articulation. Make it 3 types. Type 1 with the lateral to the L5S1 facet joint. Type B, which is through the L5S1 facet joint, the ligament. And type 3 with violating the spinal canal. This is the classification by Dennis zone fracture, as suggested by Royal Camus and modified by Steringer Wittgenstein. The subclassification of Dennis, and as we mentioned, simple flexion deformity of the sacrum, partial translation and hyperkyphotic occur. Type 3, which is a complete translation with no fracture overlap. Modified is Stringer with 1991. Baker type 4 with segmental comminution of S1 vertebral body caused by axial load of the lumbar spine into the cephalic part of the sacrum. What about the injury? The Gibson et al. Designed a useful 4-stage system specific for grade of sacral neurological deficit. He used this system as in stage 1, this patient with a fractured sacrum with non-neurological. Stage 2, the patient presented with paresthesia only, and stage 3, motor loss but bowel and bladder control, and stage 4, which is impaired bowel and bladder control. This is by Gibson. Regarding this is the stage of neurological injury. What about regarding the stability of the fracture? There is a 3-stage system of stability classified has been proposed for sacral injury. either this patient with stable or unstable. Stage 1 with osteoligamentous injury with retention of structure function, or stage B with occult osteoligamentous disruption, and stage 3 with obvious complete osteoligamentous disruption. This is regarding the stability. We have a classification of the bony injury, we have neurological, and we have stability. And any sacral or posterior pelvic fracture displacement of more than centimeter is considered to be unstable fractures. What about physical examination? It's very important when you examine. Approximately 30% of sacral fracture are identified later because the bad quality of the X-ray, improper X-ray, and improper management of the patient. Sacral injury should be suspected in any patient reported pre-pelvic pain. Any patient with a pre-pelvic pain presenting with pelvic pain, you have to suspect that this patient has a sacral fracture. The history is very important, and it is to take the history. Is it motor vehicle accident or falling from a height? The most common, and repetitive stress, insufficient fracture in osteoporotic adult patient. How to inspect this patient? The entire body must be examined. The presence of altered sensorium, soft tissue trauma around the pelvic should be raise the concern of the pelvic sacral fracture. The presence of altered sensorium, which is, remember, one of the actors, she only present her complaint only that she had diminished sensation, and by this way they discovered that she had a fractured sacrum. Palpation. This is a test for pelvic ring stability by the internal and external rotation of the iliac wing. Palpate is the subcutaneous fat fluid mass indicated for lumbosacral fascia degloving, Mori Lavali lesions. Perform a vaginal examination in the women to rule out open injury. In the patient who can walk, the presence of mechanical related low back pain, buttock pain may indicate a sacral insufficient fracture. About neurological examination, it is very important. And you have to examine. Rectal examination determines the spontaneous and the maximum voluntary rectal sphincter contraction. Light touch and pinprick sensation along the L5S1, as we mentioned before, about the saddle area. Also, pre-anal wink and bulbocavernous and cremastic reflex has to be detected. Also, vascular examination, don't forget, because a lot of neurovascular injury can be done, can be occurred. Distal pulse is very important. If different, consider ankle brachial index or angiography. All patients with a sacral fracture should have a digital rectal examination, and the female patient should undergo vaginal examination to exclude any occult pelvic fracture. It's a very important statement, and you have, this is your responsibility to detect that. What about radiology for to confirm your diagnosis? You have to do some views, which AB radiography, inlet and outlet views. Sometimes it's difficult because the complex shape and 50% are missed during this plain X-ray. But there is some finding. If you find it in the X-ray, you have to suspect this is a sacral fracture. If there is L4 or L5 transverse process fracture, you have to put it in mind this is there is maybe a hidden sacral fracture. Asymmetry of the foramen, anterior pelvic ring disruption indicates that there is a sacral fracture. A step ladder sign seen in the AB views resulting from displacement with overriding of the transverse fracture fragment indicated disruption of the anterior sacral foramen and the lumbosacral facet. This is views, and the importance of each views. AB pelvic provided limited visualization. Inlet shows the sacral spinal canal. Pelvic outlet provided true AB visualization of the sacrum. Ferguson and central conoid down modification of the pelvis. Lateral sacral simple effective radiography of the screen. And this is the way to do an X-ray for the patient with sacral fractures. What about the CT scan? CT scan is very helpful for to determine and to visualize the hidden fracture and to give you a good visualization about the fracture and if any missing fracture. The most accurate for this sacral fracture, especially for transverse fracture, useful for detecting the large defect as Traloff cyst. Diagnosis of coagulative malignant lesion can be done by a CT scan. About the MRI, it is very important to recommend when there is neural compromise is suspected. The most sensitive is detection of the fracture, soft tissue edema, and the marrow changes. Electrophysiological assessment, one of the tools, it can be used to for perineural somatosensory evoked potential and anal sphincter electromyography are useful for assessing patient with possible neurological deficits related to the sacral injury. Cystometrography performing with sphincteric electromyography and post-voiding residual measurement can be used as a follow-up test to the patient with neurological bladder. Assessment of the sacral injury, it is very important when you have and decide what we are going to do. This is 5 basic principles must be followed when assessing the sacral injury. The presence of active bleeding, this is means that there is, it is an emergency. The presence of an open fracture, it is an emergency. Neurological injury, pattern and severity of skeletal injury, and systemic injury load. So when you're facing the patient, you have to put these 5 points to help you for making your decision for the interference with this patient. The presence of active bleeding, it is a life-threatening injury to the iliac. The presence of an open fracture, it is also an emergency. The neural injury, neurological injury may be involved the coda equina and the rhombosacral plexus and the sympathetic and the parasympathetic chain. Pattern and stability of the skeletal injury and systemic injury load, the cumulative injury load to the patient has considered a short and long-term implication for the treatment. Determine the stability. So look for the stability of the fracture, impact vertical fracture, non-displaced fracture of the sacroiliac complex, and the fracture of the upper sacrum considered as stable. Determine the unstable. You have unstable fracture diastasis or of more than 1 centimeter along with an anterior unstable injury considered these unstable injuries. What about the early management? The early management for unstable sacral may be including general resuscitation measurement. As we mentioned, this is sometimes life-threatening condition, so we need a general resuscitation for the ABC and the temporary reduction of the displaced pelvic ring fracture, and this can be done by either skeletal traction, application of the anterior external fixator as an emergency placement of the pelvic clamp, or using of a wrap around the sheet. Angiography, embolization of the bleeding pelvic vessels, patient remain hemodynamically unstable. What about after that, when stabilizing the patient? Sometimes you go for non-operative management or operative management. Non-operative, if look for active modification aimed by preventing further fracture displacement. This can be done by bed rest in traction, bed rest in a brace, or simple bed rest or early mobilization with protected weight bearing. The typical time frame for healing of the posterior pelvic ring fracture, it goes from 2 to 4 months. This allows for the transitional period of protective weight bearing of 1 to 2 months. Remember, in all patients on prolonged bed rest, you have to give him this thromboembolic prophylaxis, pressure care, and chest physiotherapy as needed to prevent basal atelectasis. In zone 1, this is an example without neurological deficit, and it is stable, symptom relief, bed rest for 7 to 8 days, and don't forget what we mentioned about thromboembolic prophylaxis, pressure care, chest physiotherapy, and leg ruled for these patients. In zone 1 and 2, zone 3 without neurological deficit, bed rest for 8 weeks if it is stable, weight bearing at 4 to 8 weeks on the fracture side. Complication of the conservative treatment can be chronic back pain or chronic pain, sacroiliac joint arthritis, change in the alignment of on the sacrum, and the bowel and the bladder disability. What about the surgical decision making? It is very important we consider as the 4 things we mentioned before, the goal including fracture stabilization and the lumbosacral realignment, optimize of the chance of neurological recovery, debridement of the open wound and compromising soft tissues, minimization of additional morbidity. Time of any surgical intervention should be chosen on the basis of the treatment goal, the patient general medical status, and the invasiveness of the surgical procedure. So you put this in your mind for the patients, looking for the goal and looking for the condition of the patient. Surgical stabilization principle is very important. You have to consider the anterior perfect ring stabilization period to addressing the posterior sacral injury, method including anterior plate fixation, external fixation, or use of retrograde pubic screws. Ensure stability of the lumbosacral articulation when indicated. Anterior sacral approach, decompressed and stabilization has substantial approach-related morbidity and provided limited surgical exposure. Whereas possible, posterior sacral stabilization should offer a high degree of mechanical construct stiffness while producing a low implant profile that minimizes the risk of posterior soft tissue breakdown. This is posterior sacral stabilization, including many procedures. The one of these, the first one is the percutaneous screw fixation, and this is the screw may be placed as a sacroiliac or transsacral or transiliac transsacral screws, and this can be 1 screw or 2 screws according to the condition. Uses for segmental plane fracture if you have a segmental, not a transverse. The technique, the screw places percutaneously under fluoroscopic. Be aware of L5 nerve root, which is very important. Consequences, this may resulting in loss of fixation or mal reduction, does not allow for removal of loose body fragment if it is present in the fracture, and don't use this in the osteoporotic patient. This is the first method, and this is an example of the procedure for the percutaneous methods. And this is an example of the 2 screws, the 4 unilateral sacral fracture in the zone 1 and zone 3. Under fluoroscopic control, the reduction is obtained and held by iliac screw cannulated. The other type, which is a posterior tension band plating, this is the approach in the posterior 2 incisional approach over the sacroiliac joint. The technique may be used in addition to the sacroiliosacral screws, and can be the process of this allow for direct visualization of the fracture, the wound healing complication from the prominence of the plate. What about the posterior sacral stabilization, the iliosacral and the lumbosacral fixation? This is one of gold standard now. Approaches in the posterior approach to the lower lumbar spine and sacrum. The technique is the pedicular screw fixation in the lumbar spine, and the other in the iliac crest parallel to the inclination angle of the outer table of the ilium, and the longitudinal and transverse rod to hold this fracture and after reduction. The board is shown to have a great stiffness when used for an unstable sacral fracture. The cause for this, it is an invasive surgery, and there is some morbidity from that. Decompression of the neural element, the technique can be done by indirect technique or direct. Indirect by a reduction through the axial traction, as we mentioned, for the lumbosacral fixation, lumboiliac fixation, or direct by posterior approach followed by laminectomy or foraminotomy. This is an example of the zone 3 with neurological injury. Aggressive radiological examination is very important to confirm your diagnosis, and early posterior decompression for return of the bowel and the bladder control and reserve of the food drop. Surgical indication always in the posterior vertical displacement or both, and displacement for more than 1 centimeter, rotation unstable pelvic ring injury, sacral fracture with unstable pelvic ring that required mobilization, and neurological injury. This is open reduction and internal fixation of the fractures of the sacrum. And this is one case from our department, and we did, this patient came to us with falling from height with paresthesia, and you can see from the X-ray that the S1, S2 completely disrupted and displacement. This is a close view for the severely displaced sacral fracture. And this is coronal view, and you can see that according to the morphology, it look like Y-shaped fractures. And this is a sagittal CT scan reconstructed. And this is the close views. And this is another case, the same case, sorry. And this is three reconstructed CT. And this is pelvic ring, and you can see disruption of the both sacroiliac joint and the sacrum also. And this is the X-ray, and this is the MRI neurological to see what is the neurology and completed disruptions. And this is the CT, and this is it's look like an inverted Y. This is an X-ray, and this patient went to for him, and we do for him lumbopelvic fixation using 2 screws in the iliac bone and the screws in L4, L5, and the L5S1, make a distraction and make a 2 cross connector to increase the stability. And this is the screw, is the only available screws at that time. And this is a lateral view, and you can see the complete reduction of the sacral fractures. And this is pelvic, you can see that the pelvic is become normal, within normal. And this is the pre-operative and post-operative. And this patient video film shows that he's improving his function after the surgery, starting to have some movement. The film is not working. Okay. What about the complication of the sacral fracture? It is very important to remember that the venous thromboembolism is very important, often as a result of embolization. Iatrogenic nerve injury may result from over-compression of the fracture. If you do improper hardware placement, can leading to iatrogenic nerve injury. Mal reduction, more common with vertical displacement fractures. In conclusion, neurological deficit occur commonly in fracture sacrum. Stable fracture, go for conservative treatment. Unstable fracture, operative treatment. Neurological injury, posterior decompression is something, it is a mandatory. This is some reference. I take my presentation, and at the end ده واحد تأثر شاعر بهذه الصورة المبكية، فأنشط كل الذين يرجوا المزيد وعندها قوم من الأفضال ما أغباك. انظر لهذا الطفل يرسم ساقة متمنيا لو عنده ساقة، فاقنع بما آتاك ربك شاكرا فهو الذي من خيره أعطاك. الحمد لله على نعمته العظيمة. وفي الآخر thank you for your attention.
Thank you so much Professor Bahaa for this very interesting talk. Thank you so much. وده أحسن ختام للكورس والله، محاضرة سيادتك. أستاذنا الدكتور جلال بعد كده يا فندم.
الله يخليك، ربنا يكرمك ان شاء الله.
شكرا يا بروف على المحاضره
اتفضل يا أستاذ.
الجميله جدا، بتاعت ضافت لنا كتير قوي الحقيقه، حاجه جميله خالص. ربنا
الله
يجعله في
يخليك.
ميزان حسنات.
ربنا يكرمك.
Sir, we have one question. دكتور أشرف بيه معانا دلوقتي. دكتور أشرف. دكتور أشرف you're muted.
اوكي. السلام عليكم دكتور بهاء. السلام عليكم دكتور ياسر، دكتور محمد بيه.
اهلا
طيب بركاته يا استاذنا دكتور اشرف
اهلا
باشا.
سعادتك دكتور ممدوح.
اهلا دكتور اشرف، نور يا باشا.
دكتور
أهلا
اشرف،
بيك.
دكتور ممدوح باشا، في اي كومنت لسعادتك او اي سؤال ولا نبدا في الاسئله؟
هو في سؤال من الاودينس. دكتور بهاء خالد بشريف. How can we calculate ankle brachial index؟
دي طبعا ليها سبيشال برسنتج عشان نشوف اذا كان في انجريز للبتاع، لكن انا ما عنديش البتاع، مش حاططها اللي هي الاندكس اللي موجوده.
في سؤال صغير يا دكتور بهاء باشا.
اتفضل. يعني
في الحالات اللي بيبقى عند الفراكشر في الفيرست سيجمنت، الريسك بتاع الانجري للبايفركيشن اوف ذا اورتا،
ما ده من الحاجات الفاسكولار فعلا.
يعني في حالات بيحصل فيها مورتاليتي عاليه قوي في الحالات دي.
ما هو ده الريتروبروتينيال هيماتوما اللي بتحصل، وفي نفس الوقت عشان كده بيقول لك البي ار والفاجينال اكزامينيشن فيري امبورتنت. وطبعا الالتراسونوجرافي من الحاجات اللي هي في الحالات المهمه جدا. لو لقيت عندك ديستنشن للابدومن you have to do emergency ultrasonography and you can go for either embolization for this arterial injury or you can make an exploration.
دي تخش في الباسكر بقى، فلازم حد بتاع باسكر يبقى ستاند باي يعني.
ما طبعا ما بتيجي في الامرجنسي فتبقى الاثنين موجودين، يعني اللي هو الاورثوبيديك والباسكر لازم يكون طبعا، مش هتقدر تفتحها انت بالنسبه للانتيريور يعني.
Yes, Dr. Ashraf B, we have another questions. I see some questions, sir.
Yes, another one. دكتور وائل أبو زيد. Pardon the typing. وائل أبو زيد. If a fracture in both iliac wings zone, non-displaced with pubic rami fracture, is fixation mandatory or not?
ده يعتبر ده يعتبر في رأيي أنا يعتبر unstable fracture، وده من الحاجات اللي هي ممكن تحتاج ان انت fixed posterior fixed anterior.
I don't see any other questions.
في الاكسبيرينس with sacral plates in the in zone 3 fracture.
احنا بنستخدم السكرال بليت او سكرال رود. السكرال بليت عيبها ان هي بتبقى برومن تحت السكين. انا بستخدم السكرال رود، بدخل بين البتاع فبتبقى عندها ماسل بالك متغطيه. لكن حكايه السكرال بليت نفسها عشان تعمل كونتورنج بتبقى دايما برومننت تحت السكين، وبتعمل يعني حتى بتبقى للعيان عامله له يعني abnormal pressure area، وبتبقى discomfort للعيان. فممكن انت تعمل التو سكرال رود ده، وانا بفضلهم يعني.
انا بقصد الديسبليس ترانسفيرس فراكشر.
الامبلانت يا سعاده البيت بعدها قد ايه؟
نعم يا فندم.
الترانسفيرس فراكشر انا بتكلم على البليت.
مش سامع.
حضرتك بتقول يا دكتور جلال بنشيلها بعدها بقد ايه ولا؟ بتشيل الرادس ساعات.
ممكن 6 اشهر بتشيلها على طول، لان حتى بتعملوا ديسابيليتي في السيكرو إيلياك جوينت، لان السيكرو إيلياك جوينت من الحاجات اللي هي مهمه في الموفمنت وبتعمل ديسابيليتي.
كنت بقصد على البليتنج في الترانسفيرس ديسبليسد فراكشر سيكرم البوستيريور.
لا في البليتنج لا، هم بيحطوا هوكس بروكسيمال ادريستر ويعملوا بيها كومبريشن في الترانسفيرس سيكرال فراكشر. لكن انا لما بقول على الرود دي بتكلم في الفيرتيكال فراكشر.
لا انا بتكلم على الترانسفيرس فراكتشرز والبليتنج فيها. احنا we have an experience في البليتنج في on our department with the transverse fracture sacrum fixed with plates, bilateral plates, direct reduction and bilateral plating, and it gives very good results.
كويس. هو بس هو السؤال اللي انا عايز اقوله بقى، يشتغل فيها السكرال فراكشر السباين ولا بتوع البلفس؟ يعني الدكتور اشرف هو اللي يشتغل فيها ولا بتوع السباين حضرتك تشتغل فيها؟
الاثنين يا فندم.
اتخانقوا مع بعض واحنا واقفين نتفرج.
لا خلاص طبعا يبقى البلفس هم اللي يشتغلوا فيه.
هسيبه رئيس القسم الا مش هتاخد مكافأة.
ربنا يديك سعادة الباشا. Any other questions, Professor أشرف؟
شكرا يا دكتور محمد.
شكرا يا استاذ. في النهايه طبعا بنشكر استاذنا الكبير استاذ دكتور بهاء قرنة على تشريفه معنا اليوم في اليوم الختامي للكورس. شرف كبير لنا ان سعادتك معنا في الختام يا فندم.
الله يخليك.
الله يخليك يا سعاده الباشا. المحاضره الثانيه ان شاء الله ويل شيفت